So patient is a 63-year-old male presenting to the ER with a past medical history of hypertension, type 2 diabetes, hyperlipidemia, and stage 3 chronic kidney disease with exertional shortness of breath for the past 10 days. His symptoms begin gradually and improve with rest but worsen with walking short distances or climbing up the stairs. He describes the pain as a persistent sensation and can't catch my breath, which has slowly worsened over the last 2 days, became very severe that he couldn't even leave his house. Patient also reports a 5 to 7 pound weight gain, bilateral leg swelling, orthopnea that requires 3 pillows, and 2 episodes of waking up gasping for air. He also denies chest pain, palpation, cough, sputum, fever, chills, sweats, lightheadedness, and dizziness. His past medical history includes hypertension, type 2 diabetes, hyperlipidemia, stage 3 chronic disease, and a childhood appendectomy. Family history is notable for a father who died of an MA at 70, a mother who died of stroke of 74, and a brother who has hypertension and diabetes. His medication is lisinopril, metapro, succinate, atorvastatin, metformin, and aspirin. He also has a penicillin allergy causing a rash, and social history was not obtained. On examination, the patient is alert and comfortable with mild tachypnea but no acute distress. Vitals shows blood pressure 148/88, heart rate 102, and regular respiratory rate over 22, and oxygen saturation 91. Jugular venous dissection is absent at 30 degrees but mildly present at 45 degrees. Cardiovascular exam shows regular tachycardia without murmurs, rubs, or gallops. Lung exams shows basilar crackers without wheezing or rhonchi. There is significant bilateral 3+ pitting edema to the mild calf without any erythema or warmth. Abdomen is soft, mildly distended, and non-tender without any signs of ascites. Laboratory results shows elevated BNP 780, indicating volume overload. Renal function is impaired, and with creatine 1.8 and GFR 42, consistent with chronic kidney disease, contributed to the fluid retention. Mild hyponatremia is present, sodium 132. Troponin is normal, lowering suspicion for acute ischemia. Mild anemia is noted. Hemoglobin 11.9, which can worsen heart failure. So overall, patient is a 63-year-old male with multiple comorbidities, presenting with worsening exertional dyspnea, orthopnea, lipedema, and weight gain, along with elevated BNP and supportive physical findings. This is consistent with acute decompensated heart failure, likely on a background of chronic overload and renal dysfunction. So I'm going to admit this patient to an internal medicine servants for management, start IV furosemide for volume overload, continue the metapro and atorvastatin, hold or reassess the lisinopril based on the renal function, electrolyte monitor renal function and electrolytes daily, track daily weight, and maintain a strict input and output, order EKG again to evaluate arrhythmia or ischemia, and consider echo. And yeah.